My presentation is by Dr. Barbara Sedumedi. She obtained her undergraduate medical degree at the Medical University of South Africa in 1996. She completed her internship at Garankuwa Hospital, now called Dr. George Mukhari Hospital, where she continued to work as a medical officer in internal medicine department HIV and Pulmonology clinics before pursuing her postgraduate training in chemical pathology. In 2008, Dr. Sedumedi obtained her Master's in Medicine and Chemical Pathology degree at the University of Limpopo at the Medunsa campus. She worked as a pathologist and lecturer at the NHLS-DGM SMU complex until 2017. During this period, she was a member of the Chemistry Expert Committee and School of Pathology Research Committee and enjoyed teaching and training of undergraduate medical students. Dr. Sedumedi joined AMPATH in 2017, initially overseeing a number of stat labs around Gauteng North and peripheral labs in Rustenburg and Tabazimbi, and later moved to specialized chemistry departments at the National Reference Laboratory. She enjoys most aspects of the laboratory medicine and is a member of AMPATH Chemical Pathology Peer Group and AMPATH Clinical Trials Committees. Thank you so much for coming to present to us.
Okay. Thank you. The topic that I chose to discuss is primary aldosteronism, specifically the diagnostic workup guideline, which is mainly based on the latest guidelines from the Endocrine Society. The article was issued in August 2025. What inspired me with regards to this topic, it's to a degree based on my personal experience or observation with regards to the management of or how we approach the management of patients with hypertension. Just to mention the fact that in my family, there's history of hypertension, and some of them are younger than me, and the workup, it's to say the least appalling in terms of the usual red flags in terms of who to investigate or not. So that's why I had to review the guidelines in terms of what is the current recommendation. So the outline of my presentation, I'll first give the brief background and talk about primary aldosteronism, mainly the definition and the subtypes of primary aldosteronism. And then I'll talk about the diagnostic workup based on the latest guideline, and then lastly give a conclusion. The background starts basically with looking at the prevalence of hypertension, specifically in the South African population. This will somehow inform, the burden of the disease in our country, and as well, to a degree, indicate the need or the appropriateness of the investigation of the condition. Hypertension, according to the South African General Practitioner Guidelines of March 2025, it affects about 40 to 50% of adults in South Africa, with blood pressure control rates of less than 50% despite available treatment. I'm sure we all know that hypertension is classified into primary and secondary hypertension, with primary also known as essential, where there is no identifiable cause, whereas secondary hypertension, there is an identifiable. Having said that, and going back to my reason for, or one of the reasons for choosing the presentation. Her definition, secondary hypertension, for you to say that somebody has got primary hypertension, ideally, you should have excluded at least more relevant in terms of age, secondary causes of hypertension. So, as I said, in my case, none of the patients, including the younger ones, were sick. So the issue is, how often do we do investigations to confirm presence or absence of secondary causes of hypertension? The risk of not investigating for the secondary hypertension is that there is a probability that we'll miss some patients who have secondary causes that may be curable, and also secondary to that, improve on the cost that is usually associated with chronic treatment of these patients who typically, or some of them, have uncontrolled hypertension. Still on the background, just a bit brief background on primary aldosteronism. It is a common cause of secondary hypertension with a reported prevalence rate ranging from 3.2% to 42.5%. This slide comes from the journal that I am mainly referring to, which is a Journal of Clinical Endocrinology and Metabolism of 2025. Prevalence of primary, as I said, the general population to 42.5%, which is in patients with hypertension together with arterial fibrillation. Note the prevalence in patients with resistant hypertension, which is around 28.1%, which is also high. So it's just the prevalence rate based on different subgroups. Of note is that primary hyperaldosteronism is reported to be underdiagnosed and therefore undertreated. The postulated reasons for investigating or underdiagnosing primary hyperaldosteronism include the following. One, the traditional teaching that primary hyperaldosteronism is much more common than secondary hyperaldosteronism, with the prevalence rates of 95% versus 5% for primary and secondary respectively. The second reason is the presence of other predisposing factors for hypertension, which may sort of cloud the thinking in terms of other possibilities for the cause of hypertension. The third reason is absence of distinctive features. For example, in patients with primary aldosteronism, the common ones being resistant hypertension, and sometimes with hypokalemia, in the presence of hypokalemia. The last reason is limited resources to be able to implement the protocol for the diagnostic work. The challenges, however, with regards to under-investigating and under-diagnosis is the high risk of complications associated with primary aldosteronism, which include heart failure, atrial fibrillation, stroke, kidney disease, diabetes mellitus, and also psychological effects like the depression. Note that this risk, they are reported to be much higher in primary hyperaldosteronism compared to age-matched, comorbidity-matched patients with essential hypertension. The other challenge is the healthcare cost implication. As I indicated earlier, these patients often require more treatment in terms of trying to achieve the control for hypertension. The other cost implication may be associated with possible complications that these patients may have. Therefore, continuous review on the guidelines for investigation, management of investigation and management of primary aldosteronism is essential, with the main objective of detecting more cases, managing cases accordingly, and therefore reducing the risk of morbidity and mortality. Talked about that slide. The next slide talks about primary aldosteronism, the definition thereof. It is a primary adrenal disorder that is characterized by excessive and/or inappropriate, non-suppressible renin-independent aldosterone production. Note the inappropriate inclusion in the definition of primary aldosteronism. The challenge with regards to the diagnosis or the screening of primary hyperaldosteronism, often we look at elevated levels of aldosterone instead of looking at the aldosterone concentration in relation to the renin levels, which is why the inappropriate term is included in the definition. So with the increase in aldosterone, that will result in increased sodium reabsorption with subsequent water retention, and that will result in increased intravascular volume, which is a mechanism for hypertension. The other features, which are biochemical, is suppressed renin, which is due to negative feedback due to increase in aldosterone. With regards to the aldosterone and the increase in aldosterone and the suppressed renin, we can calculate the aldosterone-renin ratio, which is typically increased in patients with primary aldosteronism. The subtypes of primary aldosterone includes the aldosterone-producing adenoma, aldosterone-producing carcinoma, idiopathic bilateral adrenal hyperplasia, unilateral adrenocortical hyperplasia, and glucocorticoid-remediable aldosteronism, which is a rare genetic cause of aldosteronism. The most common being the aldosterone-producing adenoma, followed by the bilateral adrenal hyperplasia. Yes. The diagnostic workup guidelines, the screening for primary aldosteronism. I have on this slide included the previous or the Endocrine Society guideline of 2016. And as I said, the article, the presentations largely based on the latest guideline, which is the 2025 guideline. The reason for including the previous guidelines is to kind of demonstrate the change in terms of the criteria or the consideration in terms of who to investigate. So with the previous guideline, the clinical presentation in terms of the severity of the hypertension, meaning patients with resistant hypertension on 3 antihypertensive medication, control blood pressure on 4 or more antihypertensive drugs, sustained blood pressure, high blood pressure over 3 different days, hypertension and sleep apnea, hypertension and adrenal adenoma, hypertension and hypokalemia, and a patient with hypertension and family history of hypertension, early onset hypertension, and those who are less than 40 years of age. These were considered as the screening criteria, you know, in terms of primary aldosteronism. That was there. With the current guideline, the recommendation is a universal screening. However, this is conditional and it should be based on available resources, local expertise, and healthcare system capacity in terms of the feasibility of the screening, of introducing the screening. So the consideration to do more of universal screening is to try and increase the detection rate of primary hyperaldosteronism with the benefits that it comes with regards to targeted treatment. The test, as I indicated earlier, includes aldosterone and renin with the calculation of aldosterone-renin ratio. That's the screening test for primary aldosteronism. The testing protocol, the blood has to be done preferably in the morning with the patient seated, no sodium restriction prior to collection, and note the need for the inclusion of potassium measurement, not necessarily as a screening test, but to help in the interpretation of the aldosterone. The other point to take note of is the management of interfering medication. There are different strategies that can be employed with regards to the use of medications that can interfere with the screening. One option is to take the blood without withdrawing any medication. The second option is to either implement minimal and or full withdrawal strategy. So this slide basically summarizes how to approach, you know, the screening in patients who are on antihypertensive already, which is often always the case that the patient are already on treatment. So the first strategy, as I said, is not to withdraw any medication. And then how do you interpret the results in the case where there's no withdrawal of medication? That is not so clear, I'm sorry. Okay, if the screening is negative, the worry is a possible false negative. And then what do you do in order to confirm or rule out a possible false negative? You repeat the screen after on a different day after minimal withdrawal of the medication, and preferably in patients who have high pre-test probability of primary hyperaldosteronism, right? Okay, if the screening is positive, and you are suspecting a possible false positive results, you withdraw the drugs that are likely to cause a false positive, and those include beta-adrenergic blockers or centrally acting alpha-2 agonists, e.g. clonidine and alpha-methadone. You withdraw that for 4 weeks and repeat the test. If the test comes back positive after withdrawal of that, then the test is likely truly positive. The screen is likely truly positive. So with regards to the minimal withdrawal of medication, that includes 2 groups of drugs. The mineralocorticoid receptor antagonist and epithelial sodium channel blockers. You withdraw that for 2 weeks and repeat the test. And then the beta-adrenergic blockers and the centrally active alpha antagonists, we have talked about that with regards to the possible false positive effect that they can have in patients with suspected primary hyperaldosteronism. So essentially, the withdrawal is either you screen without withdrawing, and then if the results, if you suspect false negative, you repeat, you withdraw and repeat the test. If still after withdrawing implementing minimal medication withdrawal, still there's possible false negative, where remember the guide is the high pretest probability. Then you consider doing a full withdrawal, either 4 weeks or 2 weeks, depending on the group of drugs that the patient is on. And then the drugs, alternative drugs that can be used, it's in both instances where there's minimal withdrawal or full withdrawal, is hydralazine, alpha-adrenergic blockers, non-hydropyridine calcium channel blockers, and monoxidil. So those are the alternative drugs that you can consider using when you have to stop these drugs. And the other point of note is that you do that, you stop the drugs, considering the safety of the patient, before withdrawing any drug. On the other slide, it's basically the list of drugs that can affect the renin and aldosterone. Just so you know, when you collect a sample, which ones may have an effect and what action can be taken in instances where the patient is able to start. The criteria for a positive screening, it's typically low or suppressed renin, which is the hallmark for the diagnosis of primary aldosteronism. Secondly, it's inappropriate high aldosterone, and then elevated aldosterone ratio. Note that according to the guidelines, all this should be present. Okay, this slide basically demonstrates the different cutoffs for aldosterone renin ratio based on the assay used for the renin and aldosterone measurements. The other differentiating factor in terms of the cutoff is the unit of measurement. So it's the assay and the unit of measurement. So the cutoff differ according to groups. Okay? For instance, in our setting, we use immunoassay method. And then for the renin measurement is direct renin concentration. And then aldosterone is also immunoassay. So when we are to consider our cutoff, we need to look at the it's the assay that we are using. Therefore, we look at the cutoff that is applicable for that assay, as well as the unit of measurement for that particular method. So as I said, in our setting, the aldosterone concentration cutoff that is recommended, which is the threshold to decide on whether the screening is positive or not, it's more or equals to 277 picomoles per liter. And the ratio would be greater than 70. Our current screening ratio is 80. The challenge with the thresholds to decide on the positive or negative screening test is that there's variability based on the methods, variabilities amongst the studies performed. So what we look at more often is whether that the study that was used to determine the threshold was the method used, the analytical method used in the analysis of the aldosterone and renin method. So we would opt for the study that basically uses method similar to us. And then the other factor that we also consider is the structure of the study, in terms of the size of the population, as well as a prospective or retrospective study. So note the challenges with regards to the different cutoffs that are often used. Okay, this slide, I'm sorry, it looks too busy, but it kind of summarizes the approach that one can go through in terms of screening for primary aldosteronism. So if you've got an individual with hyperaldosteronism, the recommendation is that we measure aldosterone and renin, as well as potassium. Though the reason for potassium is not mainly to screen, but to help with the aldosterone identification. So you do that, and then you decide on whether the results meet the criteria for primary aldosteronism. Okay? As I said, there are different cutoffs according to the method used. So if the results meet the criteria based on your laboratory cutoffs, then the concern would be for a possible false positive. Okay? If it is positive, then you need to consider the possibility of a false positive. As I said, the clinical presentation of the patient or the clinical findings should help in terms of the probability of a false positive in a particular patient. In a case where there is a suspicion of a false positive, recommendation is that you stop drugs that can cause false positive screening. Remember, it's the beta-adrenergic blockers as well as the central alpha-2 agonists. So you stop those drugs. In this case, we did no withdrawal of possible interfering drugs. So you took the blood screen, and then now you are considering whether there was possible interference or not. After removing the drugs, you repeated the test. Trying to read the slide, the letters are so small. Okay, if there is a possible false positive, and you withdraw the drugs and retest. Remember, for this, you withdraw for 2 weeks and repeat the test and follow the flow diagram. If the probability for false positive is no, and the screening is positive, the pretest probability is high, then the primary aldosteronism is likely. This site, when the criteria for primary aldosterone is not met, the concern is a possible false negative results. And in this case, factors that you need to consider in terms of how to handle this patient is the presence of hypokalemia, which may lower the aldosterone, thus causing a possible lower ratio. The second is medication that can cause renin, and that can raise renin and decrease the aldosterone renin ratio. Those are the list of drugs that can affect the renin, that can increase the renin, causing a false low results. The other factor that you consider still is the high pretest probability, and then the low renin with aldosterone that is kind of borderline with the high pretest probability. If in this case there are these factors, the results are negative, so you want to check if the probability for false negative is high. If it's high, then or if the patient is having any of those, then you correct the hypokalemia, withdraw the drugs that can influence the analytes, consider basically withdraw the drugs that can interfere with the results, and then repeat the diagnosis. And then if the probability for false negative is absent or no, then the patient is unlikely having primary aldosteronism. So for these ones where there's drug withdrawal, you have to repeat the test and follow the flow diagram. This slide is basically a follow-up on this one. This would be in patients where the primary aldosteronism is likely. So we are working up the patient further to determine whether there's lateralization of the disease or not. Okay, the article or the guidelines, one of the factors that is considered in the guideline is to have a consultative management approach to the patient. The decision that is made is in consultation with the patient. So probably the primary aldosteronism, it's the screening is positive. The next thing that you consider is the patient, whether the patient is a candidate for surgery and is willing to go for surgery. If the patient is not a candidate for surgery and is not willing, is not a candidate for surgery, and or is not willing to go for surgery, there is no point in terms of waking up the patient. Maybe no point is it's a strong term. The benefit of waking up the patient further is minimal. Therefore, which is why the recommendation is that rather treat the patient medically, preferably with mineralocorticoid receptor antibodies. Screening positive, not fit, not suitable for surgery, or not willing to go for surgery, you start treatment. If the patient is suitable for surgery and is willing to go for surgery, the next step is to determine the possibility of lateralization of primary aldosteronism. Factors that we need to consider with regards to that decision is the concentration of the potassium, the level of aldosterone, and the level of the renin. Okay. If based on the result of this, the potassium, aldosterone, as well as the renin, you can decide on whether the probability is low, it's intermediate, or it's right. The low probability would be based on normokalemia, aldosterone level that is less than 3, depending on the unit of measurement. 3, I'm using this because this is our unit, less than 305 picomoles per liter. Remember the cut of the threshold for positive screening for aldosterone is 277 based on this unit. So if it's between 277 and 305, the probability of lateralizing primary aldosteronism is low. So these are the factors that you consider in terms of deciding that this is low probability, right? Let me jump to the high probability indicators for lateralization of the primary aldosteronism. You consider those factors that we mentioned there. With regards to the potassium, hypokalemia, it's highly likely suggestive of lateralizing primary aldosteronism. The very low renin concentration with the cutoff of less than 0.2 is highly suggestive of lateralizing primary aldosteronism. So this is just a different cutoffs based on the method. So in between these, the classification is intermediate probability. That is, the patient is having, it's not fitting with that and neither that. Sorry. Then you consider intermediate probability of lateralizing primary aldosteronism. And then with this group, the suggestion is that you discuss the options in terms of the further management with the patient, because it can either be lateralizing or not. So if the patient opts for not to undergo further investigation, then you can start patient on mineralocorticoid receptor antagonist. If the patient is willing to go for further investigation to confirm or to determine the probability of lateralizing disease, then you can do the aldosterone suppression testing. Uh, with patients who have high probability of lateralizing primary aldosteronism, further workup include the adrenal CT or MRI, as well as adrenal venous sampling, just to determine whether it's a bilateral or unilateral disease. However, in patients who are younger than 35 years with very high blood pressure that is resistant to treatment, as well as adrenal lesion that is more than 1 centimeter, there is really no need to do adrenal venous sampling, because already from the imaging, there is a diagnosis or identified etiology for the primary aldosteronism. So this patient can go straight for surgery without doing the adrenal venous sampling. However, generally, if in case of absence of these, you do adrenal CT scan. The reason for including the adrenal venous sampling is also to confirm or to determine the functioning of the adrenal gland, which is often not detected on the adrenal CT. So if the lateralization is confirmed, then the treatment of choice is surgery. If it's bilateral disease, then the treatment of choice is medical with mineral corticoid receptor antibodies. Okay, remember, in this group of patients with intermediate probability for lateralizing disease, the patient has got an option in terms of whether he wants treatment without further workup, or he or she prefers to undergo further testing, which in this case would be aldosterone suppression test to confirm primary hyperaldosteronism. So the next slide is talking about the confirmatory testing, that can be done to confirm primary hyperaldosteronism. So this involves a number of dynamic function tests. According to the article, these are the recommended ones. Those include the oral salt loading, the capsule challenge test, and the saline suppression test. The oral salt loading test and the saline suppression test, the physiological principle is the same, because both of them, it's salt loading, where the expectation is that will increase sodium in the blood with subsequent water, and therefore the aldosterone will go high. This is aldosterone suppression. So the increase in intravascular volume will reduce the renin with subsequent aldosterone suppression. That is the mechanism behind the oral salt loading test and the saline suppression test. So in a patient who does not have primary aldosteronism, there will be suppression of the sodium. However, with regards to the oral salt loading, the test that we do, the patient is given either sodium tablets or diet containing sodium for 3 or 4 days, and after the last day, the patient, there's collection of 24-hour urine, where we determine the urine sodium, the urine aldosterone, the creatinine is basically to determine the adequacy of the collection. So in a normal patient, the urine sodium ideally should be more than 200 milliequivalents per 24-hour collection. And the aldosterone, sorry about the letters. The aldosterone should actually be, if we're talking about the normal patient, the aldosterone should actually be low in urine because of the suppression from the note that in this patient, with this dynamic function test, this one and the saline suppression test, for the fact that there's increase in intravascular volume associated with this, these are relatively contraindicated in patients with congestive heart failure, as well as chronic kidney disease. The better option in those patients would be the captopro challenge test, which is a relatively easier and relatively better reliable test than specifically the oral salt loading test. With the captopro challenge test, the patient is given captopril. The dosage, it's either 25 milligram or 50 milligram. The decision should be based on the blood pressure measurement. Patients with blood pressure less than 120, the preferred dose is 25 milligram, and those with blood pressure above that, a higher dose of 50 is recommended. So you take baseline bloods. It might note that the patient should be sitting up during the test, and you take baseline bloods, give the pill, and then take the blood samples 2 hours after the administration of the captopril. Yeah? And it's the assessment that we use to determine whether there's suppression or not is the aldosterone, the cutoff of which is 277. If the value is below 277, then the likelihood that this patient is having primary aldosteronism, it's low as compared to values that are higher than 277. Also note that with regards to these cutoffs as well, there is variability, with regards to what cutoffs should be. In actual fact, the other indicate, because some patients may present with may have a baseline aldosterone that is not elevated, not significantly elevated, maybe just around 300. So in those patients, giving captopril may for suppression that may be, not significant in terms of confirming the suppression or not. So the other option of interpreting the results will be to look at the percentage of the value after subtractions, administering the captopril, whereby some articles refer to the aldosterone concentration that is more than 70% of the baseline. If the value is about 70% or more of the baseline, then the result is positive, meaning that there is no suppression. The principle of the saline suppression test, the patient should be sitting up. You administer 2 liters of normal saline, take baseline level before the saline, and then take the post-saline blood levels for renin and aldosterone after 4 hours of administration of the saline. And the cutoff also varies, with the cutoff of less than 217 for for the sodium. This slide basically just give and remember we talked about the adrenal venous sampling. The slide basically just give an indication on the indices that we check in terms of deciding on whether there's lateralization or not. The general approach is that we take blood samples from the adrenal vein on both sides, one close to the adrenal gland and one close to the inferior vena cava on both sides. There's inclusion of cortisol as well. The inclusion of cortisol measurement with the calculation of the selectivity index is basically to determine the success of the AAV candidation. So the selectivity index looks at that. The other indices that we look at is the lateralization, where you check the concentration or the calculation on either obtained on either side of the adrenal glands. This is the calculation that we use to determine on whether there's lateralization. The other index is the contralateral suppression index, where you check if the other side that is not affected based on the presence of lateralization disease, whether there is suppression on. So these are the indices that we look at in determining whether there's lateralization on. So, just in conclusion, going back to my story, hypertension is the most common cause of cardiovascular morbidity and mortality. Note that the prevalence of primary aldosteronism is reported to be underdiagnosed, and the concern is that patients with underdiagnosed primary aldosteronism have a much higher risk for complications compared to patients with primary aldosteronism. Therefore, continuous efforts to improve and implement as much as possible based on the practicality, the consultative approach, and cost effectiveness consideration to look for basically to determine the guidelines and treatment for the guidelines for treatment and diagnosis. So there must be continuous efforts to try and improve on the guidelines based on the practicality, the cost effectiveness, and consultative approach towards the patient. This approach will improve the detection rate, will help patients in terms of more targeted management, which may include curative surgery. The other benefit is possible reduced morbidity and mortality, as well as general patient outcome.
Thank you so much, Barbara. This is probably most detailed presentations, and I think we appreciated your time. I think for the sake of the students, we're having more than 50 students here. The question that I just, should we be screening for PA, primary hypertension in patients with the normal potassium?
Yes, that's a good question. The reason for doing that is because the hypokalemia is usually more common in patients with severe hypertension. Therefore, the absence of hypokalemia should not indicate less likelihood of primary aldosteronism. The other factor that we need to consider, hopefully it occurs rarely, is the fact that potassium, the sampling in terms of the potassium is important. Factors like hyperkalemia, factors like hemolysis, factors like delayed sample analysis may cause a false normal potassium. Hence, the normal potassium should really not be relative contraindication or screening for primary.
All right. Any question on the floor while I'm getting the rep? I have no more clients. Michael, the bones are not far away from the kidney. Right, the rep?